organism SHM, which is Streptococcus pneumonia, Haemophilus influenza, Morezella catarrharis. So, what is the organism that causes atypical pneumonia? MCL. What is that MCL? Mycoplasma pneumonia, Chlamydia pneumonia, and Legionella pneumonia. Okay, so when you talk about the onset, when the onset and community acquired, it is acute, rapid. So you will see the patient is feeling well today. Then next day, everything changes because it's what? Acute, rapid. But the atypical one is gradual. Okay. And when you talk about the symptoms, symptom community have high fever, productive cough, which we and they also have that rusty sputum. But when you talk about atypical, atypical is low grade fever. So look at the question. Is the temperature on the lower side? Dry cough, very non productive cough. Then another important thing you must remember for atypical pneumonia is that they have ENT symptoms, ear, nose, throat symptoms. For example, they will tell you the patient presents with headache or complaint of headache. That is ENT symptom. Sore throat, that is ENT syndrome. Rhinorrhea, so you can see it presents. So this is one of the biggest buzzword to differentiate atypical from community. Atypical patients have that ENT symptom. Okay, then in the chest x-ray you are going to see lobar consolidation in the community, but in atypical you are going to see infiltrate, interstitial infiltrate. It can be diffuse. We always say diffuse or patchy infiltrate. Okay, then in physical exams you are going to hear crackers, which can also be there in atypical. Okay, but one big thing about community acquired and atypical pneumonia is the treatment. Is the treatment. You will you must know the treatment. There's no two ways about it. So what is the treatment? When you talk about community acquired, you people that have comorbidity, somebody that have comorbidity like somebody that have hypertension, diabetes, any comorbidity you can think about, we use the treatment ACMQ. So what is ACMQ? A is augmentin. So remember, augmentin is stronger than amoxicillin. So don't get it confused. A is augmentin because augmentin contains amoxicillin and quavolic acid. So augmentin is stronger. Okay. Then CM is your cephalosporin. Cephalosporin, remember we have 5 generations of cephalosporin, but we are not here to talk about that generation. Sometimes they can call it cephalosporin for you in the exam. Sometimes they will just use the third generation because you will have first generation where you have your kefles, cefalazine. So we have first generation, second, third, fourth, fifth. And for the emphasis for the exam, I tell students to focus on first, second, and third because fourth and fifth is usually injection, IM or IV. So, and this is primary care. Okay. Then macrolide. Macrolide is your azithromycin, clarithromycin, okay, erythromycin. So you can combine cephalosporin plus macrolide. That can be another treatment option. Then the Q is your quinolones. So that is your quinolones, ACMQ. A is augmentin, CM is cephalosporin macrolide. Then Q is your quinolones. And please pay attention to what I'm going to say. In these quinolones, we use two quinolones here because we have other quinolones, but the quinolones that we use here is GM. What is GM? Gemifloxacin and moxifloxacin. Then when a patient do not have comorbidity, without comorbidity like a healthy patient, okay, it's not about how old the patient is because this is how to differentiate it from the old guideline. Once somebody, even if the person is elderly, that somebody is elderly do not mean that they are not healthy. So even if they are elderly, even if they are young, as long as they are without comorbidity, you are going to use MAD. What is MAD? Macrolide, amoxicillin, doxycycline.
Doxycycline.
Doxycycline. Okay. Then for the treatment for atypical, you are going to use MAD-L. This is where students get it confused. This is MAD-L, the same macrolide, amoxicillin, doxycycline, but the L, this respiratory quinolone will not be levofloxacin. Please, I don't want you to mix it up, but that is how to remember it. No, so I broke in that one again. This is the same thing that I said. Okay, without comorbidity, you use MAD. With comorbidity, you
Mm,
use quinolones and all that. Quinolones, or which is gemifloxacin, moxifloxacin, then
okay.
augmentin.
It's mad. Okay.
You can use that mnemonic, that is your face or ACE. E is erythromycin, C is clarithromycin, A is azithromycin, and the newer one, which is the fidaxomicin. You can use AC for these three most common one that we use, or you can use face. Okay, so that is very important. And this was the cephalosporin generation that I mentioned too. These are all the things that I mentioned when I was talking. So the first generation, second generation, and third generation is what you should focus more on. So first generation is where you have your cefalazine, which is your Kefles. Then you have your second generation cefuroximia. Then you have your third generation, which is your ceftriaxone. I tell you the truth, cephalosporin is one of the medication you must know for the exam, because you will use it for the treatment of STD. We use it for the treatment of pneumonia. We use it for treatment for the skin. So a lot of conditions we use cephalosporin. So for the fourth and the fifth generation, like I emphasize, those ones are more for hospital because it's usually IM. They can use it for home, but it is IM or IV. So they have to have somebody to come and give it to them. So this is the patchy infiltrate. We said in the in the in the atypical pneumonia is patchy infiltrate. In the community acquired, it is lobar consolidation. So please, this is also important thing. Just I use this time to chip in something. Know your side effects of quinolones. Quinolones. So one of the biggest thing for the exam for the quinolones is the tendon rupture, Achilles tendon rupture. So that is very important. These are other side effects. We are not doing pharmacology, but just for attention, just for you to know. Then quinolones can also cause QT prolongation, aortic dissection. So these are the things you can see. Then this is another important thing to know. When a patient is allergic, remember we said that the treatment is MAD, MAD, macrolide, amoxicillin, doxycycline. But if you have a question, patient is allergic to amoxicillin, please, this is very important to know. When a patient is allergic to amoxicillin, they cannot get for the exam, not for real life, because for real life there are other things you consider. But for the exam, if they're allergic to amoxicillin, they cannot get augmentin. They cannot get cephalosporin, and your cephalosporin is example Kefles, and also penicillin. So what can you give them? You can give them TMF. What is TMF? Tetracycline. M is macrolide, F is fluoroquinolones. This can help you in your career as a provider, because once you have a patient, oh, patient is allergic to Keflex, oh, patient is allergic to augmentin, oh, patient is allergic to amoxicillin. What do I give this patient? Then you are going to give them doxycycline, which is your tetracycline, or macrolide, which is your clarithromycin, then fluoroquinolones. But from my own experience, not from any book, from my own experience, I usually like to go with doxycycline. The reason I like to go with doxycycline is that doxycycline does not mess up with the kidney. It doesn't affect the kidney. Okay. But all these the other two medications, oh my god, macrolide, I know I did a thorough teaching on macrolide. Macrolide have a lot of side effects, including QT prolongation, including interaction with so many medication. So I always like to stay away from macrolide, but it's a choice. It depends on you. Tetracycline or doxycycline, the major problem is avoid sunlight, the photosensitivity. Then fluoroquinolones, it causes Achilles tendon rupture. So for older people and for children less than 8 years, you have to stay away from. Um, be careful, especially for children. You have to stay away. We don't give fluoroquinolones to children less than 8 years or pregnant women, except, hear what I said, except Rocky Mountain spotted fever. There are so many conditions in the exam that is except. For example, we don't give children aspirin except if they have Kawasaki disease. So, except fluoroquinolones too, even if you give it to the elderly patient, if that is the only option, then you have to monitor them for that Achilles tendon. You see them complaining that pain. So in the exam, if they tell you a patient, elderly patient is on fluoroquinolones and they are complaining of that pain, please, what should be your next action is to DC the medication. So this is our tetracycline. I know we are not doing pharmacology, but I just put in this because these are the medications we talked about. So under tetracycline is on under two. You can see it. We have the natural tetracycline because people get confused. Tetracycline is the class of medication, but under the class of medication tetracycline, there is another medication there that is tetracycline. So we have tetracycline, we have these three, which are the natural tetracycline. Then we have another one that is semi synthetic, which is where you have your doxycycline. We always say doxycycline, doxycycline. Okay. Then we have this newer one. But for the purpose of the exam, know your tetracycline. That is the most important thing. Okay. You don't need to start knowing the classes. So this is the antibiotics that we mentioned. Just a recap. The antibiotics we mentioned when they have community acquired pneumonia is either you do when they have without comorbidity, you have to do MAD. With comorbidity, you are going to do ACMQ. A is your augmentin, CM is your cephalosporin, and and macrolide, and Q is your quinolones. Okay, so these are all the things that we, in summary. So this is the chart: community acquired pneumonia and atypical pneumonia. So it's just a recap of what we have studied or talked about.